Okay, I would say it's 5:02. So a warm welcome to our virtual grand rounds in radiation oncology. Warm welcome to this new format. It's aiming to bring you the latest science, top speakers in a very interactive format. It's happening every first Wednesday a month, and it's only 30 minutes, and it's being a 15 minutes presentation and 15 minutes question and answers. The first session has been in September time. Niklas van Es was advising us on the latest news on the PACE trials in prostate cancer, and I'm very, very happy to announce the speaker of this week, Dr. David Palma, giving a talk, Provocative, top 10 provocative facts about oligometastatic disease. And the next session will be in December time, given by Andreas Rinder about circulating tumor DNA and how it could guide us in radiation. Before we get started, a quick introduction to this format. It's being endorsed by ESTRO, SASRO, and by the DECRO Society. So many thanks for their support, and also a quick introduction to our today's speakers. It's a fantastic honor and pleasure having you, David, as the second speaker. David is Professor of Radiation Oncology at the Western University in London. He holds a master's degree in epidemiology at the Harvard University, a PhD at the Free University of Amsterdam. He's not only a clinician, not only a successful scientist and entrepreneur, but also an author. He has been writing the book, Taking Charge of Cancer, What You Need to Know to Get the Best Treatment. But obviously we know him from his clinical trial activities, and that's the most important reason why we invited him. He's the PI of SABR Comet arrest trials, so practice-changing trials in the field of oligometastatic disease. This is the fact, but there's other reasons why I am very happy to have you here in this meeting. You're one of the most innovative researchers in the field of radiation oncology, doing practice clinical trials in fields which we haven't been thinking about before. You're doing that successfully in a very pragmatic way, and you're a perfect collaborator to build teams and make them strong. So usually when I am offered to participate in a clinical trial, I ask for the protocol and then see what is being done there. And then, well, at some point of time, you make a decision. With any project you're doing, David, I'm doing it the opposite way. I just say yes, participate for sure, and then maybe I have a look what is happening because I know it's going to be fantastic. So David, many thanks for joining. We're looking forward to your presentation. To everyone, unfortunately, we don't have a video of David, so I have to apologize that somehow we screwed up Zoom. But most importantly, your voice is going to guide us, David. Thank you.
Thank you, Matthias. And if I'll share my slides, once you stop sharing. It's really good to have everybody join today. And, we're very good with our technology, but sometimes we can't get Zoom to do what we want to do. But that's okay, because the webinar might be better if you can't see me. Who knows? What I wanted to do today was a short but punchy talk, giving a top 10 list, top 10 provocative facts about oligometastases that every oncologist should know. And I hope you'll see that I tried to be very direct with these points, sort of like a German, Northern European speaker who is usually more direct than the Canadians. My disclosures are here, not related to the topic at hand. And it's a very short outline. So top 10 provocative facts about oligometastatic cancers, with my apologies to David Letterman for stealing his format. Okay, we're going to count down from number 10. Number 10. We will never have an exact definition of oligometastases, and I'm going to explain why I don't think we will ever have an exact definition. Right now, we know there's no generally accepted number, and 1 to 3 and 1 to 5 are the most common definitions for oligometastatic disease. Some people might say, well, just look at the clinical trials and look at the inclusion criteria for the clinical trials, and that will give you a definition of oligometastatic disease. But when you try to do that, you find that it just doesn't work. I have here 3 of the 4 RCTs done in lung cancer for oligomets, Gomez, Iyengar, and Sindus. And looking at the different populations that are enrolled, it's quite different. So these 2 have non-small cell. This is non-small cell EGFR mutated. These 2 allowed prior systemic therapy or required it. This one said no. They all allowed primary tumors. But then when you look at how everything was counted, it's very different. In the Gomez trial, if you had 5 lymph nodes in the mediastinum, that was allowed, and that was counted as 1 lesion. 5 nodes, 1 lesion. In the Iyengar trial, they were allowed, and they were counted. So 5 nodes, 5 lesions. And in the Sindus trial, they were allowed, but they weren't counted at all. So 5 nodes, 0 lesions. And then if you look at the number of METs allowed in total, it varied up to 3, up to 6, up to 5. And all of these trials showed a benefit. So we're not going to be able to rely on the clinical trials to give us a perfect definition of oligometastases. And the other reason why I think we'll never have a concrete definition is because when you think about what it implies, what the word oligometastatic implies, you'll realize that we won't get to a definition. And let me explain what I mean. If we use the word oligometastatic to indicate when there's a chance of cure, that's actually a very reasonable thing. Patients with 1, 2, or 3 METs are curable, maybe, so we'll call them oligometastatic. Well, the problem with that is that for most cancers, we don't even have a definition of cure. When is a breast cancer patient cured? When is a prostate cancer patient cured? Is it 5 years, 10 years? Is a glioblastoma even curable? And even if we did have a definition of cure, which I don't think we do or we will, I don't think it's likely that we'll have a cutoff where after 3 METs you're curable and 4 METs you're not. It's going to be a decreasing probability. So for these 2 reasons, I don't think we can define oligometastatic based on a chance of cure. So what you could say instead is that we're going to use the word oligometastatic for patients who could benefit from ablative treatment. So if you have 5 lesions and you benefit, even if we don't cure you, we extend your survival, then that's oligometastatic. But there's another problem with that. As you'll see in a few slides, we might be going beyond 1 to 3, 1 to 5, 1 to 10. We might be even going beyond 10 lesions. And so if we show that we can improve survival, say in people with 15 lesions, are we going to use the word oligo for 15, which is clearly not oligo? So I don't think that this definition will ever work. So what do we do? You know, I'm raising this issue. I think we're always going to rely on consensus definitions of oligometastatic. Dr. Guckenberger has pioneered some of those himself, but I don't think we'll ever be able to say, okay, 3 is oligometastatic and 4 is not. Okay, number 9 on the top 10 list. We have a lot of randomized evidence showing that we can help people by using ablative therapies. Evidence-based medicine is not about waiting for phase 3 trials and making all your clinical decisions based on that. I remember a talk, actually, Dr. Guckenberger, that you gave once where you talked about how few interventions in medicine are supported by phase 3 data. It's actually quite few. So evidence-based medicine is more about making the best decision you can with the evidence you have. And here are all the positive trials that I'm aware of in the oligometastatic space. It's a very busy table. I'm not going to go into a lot of detail, but it's just broken down by histology. So non-small cell prostate, colorectal, and multiple histologies, the author, trial name, the phase of the trial. One is a phase 3 trial, the intervention that was used, and the benefits. There's only one negative completed trial, BR002, that I'm going to tell you about in a few minutes. So the evidence is overwhelmingly positive. And if you look at the evidence overall, it strongly supports that most of the evidence is for SABR. 7 out of these 10 trials used SABR. 2 allowed radiation or surgery, but most of those had radiation. So the evidence supports treatment, and the evidence also supports SABR more than any other modality. Number 8, we know that SABR is very safe. I won't go through all the data, trying to keep this to be a fairly quick talk, but this is a really good paper if you're interested in SABR toxicity from JAMA Oncology, a systematic review and meta-analysis of the trials of oligometastatic cancers. I'm just going to show you the forest plot for grade 3 to 5 effects across all the trials. There's a very similar forest plot for late effects, and these are all the toxicity rates in the trials. The overall rate of grade 3 to 5 toxicity is only 1.2%. And I challenge you to think of any other modality that we use for treating cancer patients that only has a 1.2% chance of grade 3 to 5 toxicity. You could even say, does observation have a higher rate of toxicity? Because of course, an uncontrolled tumor can give you some complications. Number 7, this brings us to BR002. For indolent cancers, there's no benefit in the early years of follow-up. And this is, I think, the best conclusion so far from BR002. BR002 was a negative trial, and it's the only breast-specific randomized trial that we have. It did a phase 2 component that didn't move on to the phase 3. Basically, patients with up to 4 metastases who'd been on systemic therapy for up to a year were randomized between systemic therapy or systemic therapy plus ablation of all mets. But when we look deeply at BR002, more than half only had 1 metastasis, and 80% had ER, PR positive disease, HER2 negative. So you could guess here that half the patients had a single lesion that was ER, PR positive. So a disease where we know we have very, very good systemic therapy options. And this is Steve Chmura, who I congratulate for completing this very important trial, showing that there's no PFS benefit, although the median follow-up is very short. And we know from other trials, like one of the colorectal trials that was on my list before, that the benefits of ablative therapies often show up late. So for now, BR002 is negative, but I don't think it conclusively shows that there's no benefit. Another interesting sub-feature of BR002, when you look at overall survival, people with 1 MET, for some reason, had worse overall survival if they were randomized to the ablative treatments, whereas people with more than 1 MET had a significantly improved overall survival. This is exploratory, but still very provocative. So my take-home message, and this is number 7 on our top 10 list, is that patients with a low burden of disease and excellent systemic therapy options will not show a benefit within the first few years. I think that applies to any cancer that we see, whether it's a low-grade sarcoma, perhaps, or whether it's a prostate cancer with a lot of good treatment options, hormone-sensitive prostate cancer. But, you know, we never use the word cure in our practice, or we don't use it very much, but some patients are definitely cured after treatment. The first report of a patient being cured with limited metastatic disease was in 1939, so this isn't new news, but I want to show you a case. This was a patient of mine with an adrenal metastasis from colorectal cancer. The left adrenal has a metastasis in it. I don't have the GTV contour on. I don't have the contours on. This is the plan, a very heterogeneous plan delivering 60 gray in 8 fractions with compromise of the PTV anteriorly to keep the stomach in tolerance. This patient was treated on a trial, and 10 years after treatment was discharged from my care. He only had this calcification here, there for several years. So you think, well, you know, this is an anecdote. Well, it is an anecdote, but it's also the first patient randomized on the SABR Comet trial. 10 years, no recurrence. Is he cured? I think insofar as we can use the word cure in cancer, this guy is cured. No systemic therapy in the meantime. So we can cure some people. But number 5 on the list, most people are actually not cured. So this is important when we have our consent discussion, and that's because of micrometastatic disease. When you look at the results of SABR Comet, this is progression-free survival here. You see that progression can happen pretty quickly. Within the first 6 months, you have about a third of people progressing, mostly in distant locations. And by 5 years, you have only about 20% free of progression. So most people are going to recur. So when I consent my patients, I tell them, we're going to treat the spots that we can see. Unfortunately, most people have new spots pop up, and we'll treat those with SABR if we can, but sometimes we can't, and then we'll rely on systemic therapy. So it really affects our consent discussion. And so why are these micrometastases so important? Well, number 4 on the top 10 list is that metastases seed other metastases. This was very clear from some of the phylogenetic studies of different cancers where they sequence tumors and metastases in the same patient. And you can see that metastases can seed other metastases. But my favorite data that shows this is from the Oriole trial. The Oriole trial was one of the prostate SBRT trials for oligometastatic disease. Patients were randomized to SABR versus observation, and they would get hormones on progression. This is just the overall PFS for the study, where they treated all the lesions they could see based on CT scan. They found that SABR was better than observation for PFS with a p-value of 0.002. So patients had their radiation planned based on CT imaging. But all the patients also had a PSMA PET at baseline. that PSMA PET wasn't used for anything clinically. But after the trial was done, they went back to look and see, of those patients with a PSMA PET, who had lesions that were not seen on CT and therefore were not treated with SABR. So who had untreated lesions? And the patients with untreated lesions, these are the ones only visible on PSMA PET after the fact, had a much worse PFS than those who had no untreated lesions. So leaving lesions untreated, the PFS is similar to just observation. And when you look even at distant metastasis-free survival, so these METs seeding other METs, if you have untreated lesions, they seed other metastases, and you have a terrible distant metastasis-free survival with nobody free of metastasis, further metastasis by 18 months. So this is one of the pearls, I think. If you're treating with SABR for oligometastatic disease, maybe treat all lesions you must is a bit of an overstatement, but treat all lesions you should if safe. Leaving a lesion behind, I think that should be a good reason for that. Now, some people want to treat only one lesion based on a potential abscopal effect, but number 3 on the top 10 list, the abscopal effect is MIA, or missing in action, just like my camera feed today. So here is probably the best abscopal trial that I know of. This was led by Piet Oost, who is in Belgium, one of the European stars of radiation oncology, and an all-around great guy. They randomized patients who were already on immunotherapy for other reasons to either just go on the immunotherapy or get SABR, up to 3 lesions in this 3 × 8 grade dose. And these are 2 different curves here. You almost can't tell that they're 2 different curves because they overlap so much. This is PFS and this is OS. So treating for the abscopal effect, I think, is not a good idea. It might be that we don't have the right recipe yet. We don't have the right combination. Maybe we don't have the right radiation dose, but maybe not the right fractionation. But for now, I think abscopal is hard to find. Number 2 on the top 10 list, everybody always laments the fact that radiation oncologists are always behind on, does our radiation work with systemic therapy? Is it safe to give? The problem is we're always going to be behind. I think we have to accept that we're always going to be behind, because if a new drug comes out tomorrow, if someone invents a new drug that works for a certain cancer and it's brought into the clinic, we won't have data because it's a new drug, unless somebody wants to test radiation with all the unproven drugs that are in the pharmaceutical companies' pipelines. So I think we have to accept that we're always behind. And I think the best thing to do is to realize that there's going to be a lot of uncertainty around how to best use these medications. This was a very helpful paper by Dr. Guckenberger's group looking at several different, not only targeted agents, but systemic agents in general. This is only one of the tables in the paper, figures in the paper, showing what different experts suggested around whether to hold or not hold the drugs. And I don't think anybody knows 100%. So I think you have to use your judgment to some extent. Our personal approach here at our center is that we don't hold hormones, we don't hold immunotherapy, we hold targeted agents for 2 days before until the end of radiation, although some patients don't want to do that. And we hold cytotoxic for 5 days before. But that is just kind of an opinion that is probably safe. But on the systemic therapy topic, it does probably help. Here's some data from the SABR-5 prospective trial, which was done in British Columbia, which is on the west coast of Canada. And it's a large prospective cohort that they opened once SABR Comet closed in order to put people on at least a registry. And these are people treated with SABR for oligometastatic, sometimes oligoprogressive disease. And they found that if you were giving systemic therapy around the time of treatment and afterwards, you had a better overall survival. This is not randomized, but it does suggest that treating these micromets probably helps. And then the last one, number 1 on the top 10 list, well, there is more phase 3 data coming, but things might get a little bit crazy. So I'm going to show you what we're doing here in Canada with help from many collaborators, including the group in Zurich and also elsewhere in Europe and in Australia. If you were to put this plot of number of metastases in the controlled primary space, we have SABR Comet 3, which should finish accrual next summer, 300 plus patients, primary endpoint overall survival. SABR Comet 10, 4 to 10 Mets, 200 plus patients. It's about a month away from completing accrual. primary endpoint overall survival. Beyond 10 Mets, we've completed the ARREST-1 phase 1 trial, which we hope to be presenting at ESTRO in Glasgow. And we're on to the phase 2/3, which might give you a hint about the phase 1. This is also an RCT, primary endpoint overall survival. For ARREST, we also said, well, if you have a uncontrolled primary tumor, if we're treating 12 lesions, we might as well treat the primary. So that is allowing both. And then we're also opening SABRE Sync, which is to fill this gap here for uncontrolled primary tumors. These two trials have not accrued anybody yet. We're just ramping them up. Just to give everybody a bit of an arrest themselves, here is a radiation plan from a patient with numerous metastases showing that 30 gray and 5 fractions was plannable in this scenario, but more detail to come. This should not be done outside the context of a trial. So I wanted to close with about 5 or 10 minutes for questions. Number one, closing thoughts. We have numerous positive RCTs and some patients with oligometastases can be cured. I think that's pretty clear. I do still think we need phase 3s. That's why we're doing them. SABRE is the modality with the most supporting randomized evidence. So when you're at your tumor board, I think that's a good point to make. SABRE is not the same as RFA. It's not the same as surgery. They have their pros and cons for sure. And surgery does have some advantages, but SABRE has the most supporting randomized evidence. And then finally, we have learned a lot over the past decade, but there is much more to learn, and phase 3 trials are coming. So thanks for joining. Sorry that you can't see me in person, but that's how it goes sometimes. Here are a couple of practical papers if your center is implementing a SABRE program for oligometastases. And if we don't have time to get to your questions, feel free to send me an email at the email address here. So with that, I'll stop and we can take some questions.
Thank you very much for an excellent talk, David. That was fantastic. And we have quite a number of questions here. And I would like to start actually with not a question, but a quote. So we are very happy to have Ralph Weichselbaum from Chicago here in the webinar. Ralph, many thanks for joining. I mean, all these talks and clinical trials we're doing today, this is based on your experience, based on your seminal editorial paper more than 20 years ago. If we get some wind in our face today, I don't want to imagine what kind of wind you had in your face when you first described oligometastatic disease. So your comment, life isn't curable at all. Well, sadly, that's unfortunately. The central issue is pace of disease progression in addition to numbers, so the dynamics of the disease. The basis of 5 was Joe Salama coming to my office saying, hey, what did I say, 5? And for excellent analysis of BR002. So congrats, David.
Thank you.
And thanks again, Ralph, for joining. There's a couple of more questions. That one question is coming to the cutoff in your daily life. So what cutoff number of oligometastases do you use, David, in your day-to-day clinical life? Is it a fixed number? Do you adjust it? How do you practice it?
Yeah, so what we do here is, we're lucky because we have these trials open. Our group actually hasn't randomized a lot to COMET-3. There were issues with equipoise even with the first trial, so we've only put on about 10 patients. So we are treating 1 to 3 as we're offering treatment. 4+ we're putting on trial. But to be honest, so I would say the answer to that is 3. To be honest, though, it's getting harder to do these trials because people are less happy with the SABRE arm. In the STOP trial, which some of you will have seen at ASTRO, which was an oligo progression trial, we had a large number of patients, well, a minority, but a substantial minority who said, I don't want to be on the standard arm, I'm leaving the trial, which I can understand. So I think we have this trial open, so we've set the cutoff of 3. I think if we didn't have any trials, I think 5 is the most reasonable based on the trials that we have so far. Volume makes a lot of sense. It's just, and I think you can consider it kind of empirically when these are big Mets, then it's worse. There's not really a practical way to measure it all and make a decision based on that. And Dr. Weichselbaum, he's right with his very similar comment that pace is also very, very important to consider. If things are going very quickly, there are likely going to be more Mets very, very soon.
There's a couple of questions about the statement of BR002 in terms of benefit in indolent disease. One question from Nelek is, how can we show a benefit in indolent tumors, or is there any benefit at all? Should we use different endpoints?
Yeah, these are really good questions. So someone also asked, and this is a similar question, why does the benefit take so long? And is it true for PFS and OS? probably more for OS. And so PFS didn't show a benefit in BR002, which I'm aware of. But you have to think about someone on the standard arm and how long it would take for them to have an event without SABR. So let's say the event is death. And that's when you're going to see a difference between the arms. So if you have two women with each has a single breast cancer met that's ER positive, let's say it's in their spine, right? One gets SABR, one does not. You follow them. Let's say SABR has cured them and the other patient was not cured. How long is it going to take for there to be an event in the patient who did not get SABR? That could be like 8 to 10 years. And if you look at the curves from SABR Comet, which had all these histologies, of course, the curves separated around 2 to 3 years. In the colorectal trial, the EORTC trial that was in my chart, where they gave RFA to liver mets, they didn't see an OS benefit at first up until 5 years. And then at the 10-year follow-up, they did see an OS benefit. So it can take a while. So I think for these indolent cancers, it could take 10 years. You know, if you have a prostate cancer trial like Stampede, where they treated the primary, that takes a long time to show that kind of a benefit. So I agree, other endpoints might be useful. I just am not exactly sure which ones. I think we just need more time. And I should also say that with more time, I could be completely wrong, and BR002 could show no benefit, and maybe it's the biology of breast cancer. So I don't want to be too optimistic on that, but I would be willing to make a moderate bet, maybe a beer or a pizza, that we'll see a beer and a pizza, we'll upgrade it, that there'll be a difference maybe in the 8 to 10 year range.
David, there's 210 participants, even one beer and one pizza for everyone in the audience. It's going to be large.
It's going to be a lot. I think it's covered by Estro, though.
Yes, I need the treasurer. If we say that it might be more difficult or we have to wait longer in indolent disease, how about the aggressive disease? There's a couple of questions asking, should we select or have clinical trials specifically addressing more aggressive disease? How about prostate cancer? Is it the best choice to treat patients having a hormone sensitive, or might it be even better patients having a castration-resistant prostate cancer? So how about that?
These are great. We should all have a big symposium and we'd have time to go through all these. These are really good questions. So I think probably what's going to be, if I had to just guess in a crystal ball, what's going to define this risk better, it'll be things like pace of disease. It'll be things like circulating tumor DNA, right? The difficulty with doing trials based on something like circulating tumor DNA, we've been trying to think of one that we could launch, is you need to be certain that your marker is a really good biomarker before you invest 10 years of your life in seeing if you can escalate or de-escalate based on that. I also want to point out that it's very difficult to do histology-specific trials. And outside of NRG or really, really big cooperative groups, it's hard to get enough patients for a prostate-only trial and a breast-only trial. You know, BR002 took several years. LU002, same thing, still waiting for the results. So are we ever going to have a pancreas trial? Are we ever going to have a head and neck trial? I don't know. Maybe small ones with PFS as the endpoint. It's hard to say, you know, should we be treating aggressive, non-aggressive? It's very hard to know. We know that people with less aggressive disease live longer, right? So they have, if someone has a slow growing cancer, we know they live longer than somebody with maybe an aggressive lung cancer, but it doesn't mean that the patient with the aggressive lung cancer doesn't benefit. Maybe they're not going to live 10 years, maybe they're going to live 5, but maybe you're extending it by a little bit. So these are questions where I think we have to, as clinicians, just make our best informed decisions. And then you kind of come into a practice pattern that is consistent with the evidence, but different clinicians might have different practice patterns that are still consistent. And, you know, Matthias, you and I could treat a patient differently, and both could be consistent with the evidence.
We have a total of 36 questions, so we could kind of continue for another half of hour. So we will start, save the question. Maybe one last one. You showed us the clinical trial portfolio where you go beyond 5 fractions, and there was a question in the chat. Do we have the technology already to treat more than 5 metastases safely, or do we have to wait for this next generation of technology, which will make life more easy?
Yeah, good question. So I'll tell you a bit about what we're doing. So for Comet 10, which is the 4 to 10 metastases, the doses in that trial are a little bit lower than the original SABR Comet trial. They're the doses in Comet 10. The doses there are the ones that have a BED of about 60, so 35 gray and 5 fractions. 20 gray in a single fraction. And we found that in terms of the planning, it was actually very easy. And patients needed a pre-plan to get into the study. The radiation to be planned beforehand. And there were very few failures in the single percent digits. The toxicity, I don't have that data yet, so we don't know. When we look at the arrest patients, and as I mentioned, the phase 1 data is still to be presented, but we're on to the phase 2, 3. I think we could really use some better technology there. And when you look at that slide that I showed, someone looked at this and said, wouldn't this be a good thing for protons? Maybe. We need ways to make it easy to plan, contouring 15 lesions, and then, some of them are in different respiratory phases, and then adding PTVs. There's a big risk of error, and it's a lot of work. So I think this is an area where we need better technologies, both for target delineation, also for radiation planning, where do we put the ISO centers, how many ISOs, and then also treatment delivery. So this is where I think we have to lean on our physicists and our engineers to help us with some new tools.
Okay, so for the brain, we actually have that. I mean, we are treating multiple brain metastases with one single isocenter. And also in Zurich, we're currently preparing a small randomized trial on single versus multiple isocenter for treating multiple extracranial metastases. Because I think if we kind of select the metastasis in the right way, we don't need a single isocenter for each lesion already today.
Right.
Well, it's 5:33. David, that was a fantastic presentation. That was even a more and better discussion. I have to apologize for everyone who asked questions where we did not have the time. Please, I hope that was this is possible that people kind of send the questions to you, David, and get them answered. There's the email. Could you stop sharing? Then I can share my screen again. So many thanks again to you, David, for joining. And I would like to remember everyone, this is a monthly meeting. It's happening on every Wednesday, first Wednesday in a month, 30 minutes from 5 to 5:30 Central European time. And I already now would like to invite you for the next meeting, December 12th, Andreas Rimler from the Memorial Sloan Kettering, asking the question, can radiotherapy for lung cancer be guided by circulating tumor DNA? Lung cancer, but also other malignancies. Thanks everyone for joining. Have a fantastic evening, morning or day, whatever, and looking forward to see you face to face, but also in the next virtual Grand Round meetings in 1 month. Thank you.
Bye, everybody.